Hello, this is Mirrakhimov speaking. I'm one of the cardiac anesthesiologists at the University of Kentucky, where I also serve the director of point-of-care ultrasound within the Department of Anesthesiology. Today we'll be talking about the basic introduction to cardiac point-of-care ultrasound part 1. There will be a second part to basic cardiac POCUS, followed by 3 advanced cardiac POCUS talks. Let's go. I have no conflict of interest to report for this particular presentation. The agenda for today's presentation include to review the indications for cardiac point-of-care ultrasound, to understand its limitations, to appreciate the different ultrasound probe maneuvers and manipulation techniques, and also learn about the standard 5 cardiac POCUS views with relevant anatomy. So what about the indications to perform a cardiac point-of-care ultrasound? There are way more indications than which are present on this particular slide, but some common ones include pre-anesthetic assessment of a patient who has signs of cardiac disease such as murmur, body edema, jugular venous distension, signs of heart failure, and dyspnea. Point-of-care ultrasound should also be performed in a patient who is hemodynamically unstable to rule out significant myocardial dysfunction, to exclude major valvular heart disease, and also rule out clinically significant precardial effusion, among many others. Of course, cardiac point-of-care ultrasound is an essential bedside clinical tool, but everything has some shortcomings. Here are some of the limitations of cardiac point-of-care ultrasound, which include difficult acoustic windows in obesity, pregnancy, advanced lung disease, presence of surgical dressings, subcutaneous emphysema, post-cardiac surgery. Equipment is often inferior to dedicated echocardiography machines used by our cardiology colleagues, so you're limited by the amount of fancy calculations and measurements you can do. There's a possibility of operator inexperience who is performing POCUS, and also POCUS is not a substitute for comprehensive transthoracic exam. So let's talk about the cardiac ultrasound probe, which is also known as phase array probe. It is a small footprint probe, which means it's about 1 to 2 centimeter wide. It allows it to feed narrow rib spaces. It produces a triangular image. A cardiac ultrasound transducer is a low-frequency transducer, typically ranging from 1 to 5 megahertz. When you're operating a point-of-care ultrasound machine, it's important to change the preset to cardiac preset. You will notice that the dot on the screen will get moved to the right. Again, by choosing the cardiac preset, you will see that the dot on the ultrasound screen will move to the right side of the screen. It is very important for us to learn some of the probe manipulation techniques to overcome very limited and narrow imaging window of the heart with surface point-of-care ultrasonography. Remember, we are very limited by the ribs, bones, and lungs. Here are some of the probe manipulation techniques which we can use to optimize the image. This includes sliding, rotation, tilting, and rocking. We'll have some brief videos describing how to perform these maneuvers. Here you see sliding of the probe. This video you see the rotation of the probe. Next one is tilting. Another name for tilting is fanning. And here you see rocking of the probe. Please pause the video if you need more time to review this slide. There are 5 standard views of cardiac point-of-care ultrasound, which include parasternal long axis or plaques, parasternal short axis, apical 4-chamber view, subxiphoid 4-chamber view, or commonly known as just subxiphoid, and subcostal inferior vena cava or IVC view. First, we go through the parasternal long axis view. In order to obtain this image, you place the probe at the left parasternal line in the 2nd to 5th intercostal space. You orient the ultrasound probe dot towards the right shoulder. Here on the top you see a video clip of a properly positioned parasternal long axis view. So let's talk a little bit more about the parasternal long axis view. You want to display the left ventricular cavity in its largest diameter. A properly imaged parasternal long axis view does not include left ventricular apex. You want to assess the right ventricle, left ventricle, including the left ventricular outflow tract, aortic valve, ascending aorta, interventricular septum, left atrium, mitral valve, pericardium, and descending aorta. On the top right, you see a frozen image with delineated anatomy, and on the bottom right, you see a video clip of a properly performed parasternal long axis view. You want to assess the ventricular motion, ventricular function, sizes of the cavities such as right ventricle, left atrium, LVOT. Also, you want to assess for presence of any effusion, whether it is a pericardial effusion or a pleural effusion. A common teaching is that the normal parasternal long axis view, right ventricle, aorta, and aortic valve, and left atrium should be about the same size. If something is bigger than the rest, that is probably enlarged or dilated. Please take a moment to review this slide if needed. Next, we talk about parasternal short axis view. Once you obtain the parasternal long axis view, you rotate the probe and aim at the left shoulder. Here's a video clip of a properly done and performed parasternal short axis view. On the top of the screen, you see right ventricle, followed by interventricular septum, an LV cavity, papillary muscles. You see all four walls of the left ventricle here, including septal wall, which is adjacent to the right ventricle. Opposite to the septal wall is your lateral wall. On top of the ultrasound image, away from the septal wall, is anterior wall, and opposite from anterior wall is your inferior wall. In this view, you can compare the size and function of both ventricles. You can assess the position of interventricular septum, assess the contractility, and also assess for presence of pericardial effusion. Please pause the video if you need more time to review this slide. Next, we talk about apical four-chamber view. Sometimes it can be challenging to obtain, and placing your patient in the left lateral decubitous position can often improve your image drastically, obviously unless prohibitive by patient's pathology. You place the ultrasound probe aiming towards the left shoulder in the fifth intercostal space at the mid-clavicular line. Quite often you'll need to manipulate the probe in order to optimize the image. Let's keep discussing apical four-chamber view. On the top right, you see a frozen image with delineated anatomy. On the bottom right, you see an image and a video clip of our apical four-chamber view. In this view, you see septal wall of the left ventricle, lateral wall of the left ventricle, tricuspid and mitral valves, right ventricle, and both left and right atria. In this particular view, you want to assess the size and function of the chambers. You're going to look for any gross pathology of the mitral valve and tricuspid valve, and also assess for any present pericardial effusion. Please pause the video if you need more time to understand the slide. Next, let's review subcostal four-chamber view. You want to place the transducer below the side fluid process with a marker towards the patient's left, as shown in this image. You also want to aim slightly at the left shoulder. Sometimes, in order to relax the abdominal musculature, you can ask the patient to bend or flex his knees or her knees, if not prohibited by patient's pathology. Please pause this slide and video if needed. So let's keep talking about the subcostal four-chamber view. On the left part of the screen, you see a frozen image with delineated anatomy. And here you have a video clip showing you a subcostal four-chamber view. So quite often it is helpful to use the liver as a great acoustic window in order to help you find the view. In this particular view, you want to assess the size of the chambers, biventricular function, and presence of pericardial effusion. Please pause the video if you need more time to review this slide. And finally, let's discuss subcostal inferior vena cava view. From the subcostal four-chamber view, you change the transducer dot orientation towards the patient's head or cephalad. You want to avoid an off-axis imaging, and you want to ensure that you're finding the greatest diameter of inferior vena cava. Let's take a look at the IVC view one more time. Here on the left, you see a frozen image showing you the anatomy of this particular view. And on the right, you see a video clip demonstrating you the same. Please pause the video if needed to review this slide. So let's review how inferior vena cava appears on ultrasound in comparison to abdominal aorta. I find that it is often an area of confusion. So aorta, in comparison to IVC, is anterior to the spine and to the left of the spine. Aorta is a pulsatile vessel. Hepatic veins, which are thin-walled vessels, empty into IVC. And IVC, in turn, empties into right atrium. Let's take a look at this video clip next. Here you see some sort of vessel. You see probably liver on top of the screen, and you see vertebral bodies underneath. You don't necessarily see any hepatic veins draining into this vessel, and you don't see that this vessel empties into right atrium. Let's compare it to this image here. Here you see liver, you see thin-walled hepatic veins coming in and out and draining into the IVC, and you see that IVC is emptying into the right atrium because you see the right atrium and a tricuspid valve. So the top right image is image of the IVC, and the bottom right is image of the abdominal aorta with branches such as celiac axis and superior mesenteric artery. Again, it is not surprising that sometimes it can be confusing, but in the vast majority of cases, you'll be able to easily differentiate between the two vessels. Please pause the video if needed to review this slide in more detail. So what are the uses of IVC ultrasonography? It can sometimes be helpful in assessing the volume responsiveness and volume status. It can be helpful to see if the patient has tamponade physiology. Our cardiology colleagues quite often use IVC to help estimate the central venous pressure, or CVP. It can also be used to help proper positioning of intravascular devices, such as, for example, venous ECMO cannulas. Please pause the video if you need more time to review this slide. The concept of fluid status and fluid responsiveness is important. So what fluid responsiveness means is that if you give an additional bolus of fluid, do you increase the cardiac output and improve the perfusion or not? Again, it's important to remember that both hypovolemia and hypervolemia are associated with adverse outcomes. And unfortunately, clinical exam has very limited sensitivity and specificity in deciding who is volume responsive or volume down and who is volume overloaded. You have few references of interest to review on this slide. Please pause the video if needed. When assessing the role of inferior vena cava ultrasonography in determining which patients are volume responsive or not, it is essential to keep in mind that spontaneous or negative pressure ventilation and positive pressure mechanical ventilation represent completely different physiologies. It is important for us to review it here, since this will be a foundation to understanding more advanced topics in the future. Let's describe the physiology of spontaneous ventilation. This is an oversimplified slide, but nevertheless, inspiration is an active process. The pleural pressure further drops, becomes negative, which draws and sucks the air in, but the same mechanism, and because of the gradient, the venous return to the right heart is increased. Expiration is a passive process. Pleural pressure returns back to baseline, air is exhaled, and the venous return is reduced compared to the inspiration. So what about the positive pressure ventilation? The inspiratory breath is given under positive pressure by the ventilator, which exceeds the atmospheric pressure. Because of the positive pleural pressure, the patient will have a reduced venous return. Expiration process is passive, which is similar to spontaneous ventilation, and the pressure returns back to baseline unless PEEP or positive end expiratory pressure is applied to the ventilator circuit. So what about the utility of IVC in estimating fluid responsiveness in spontaneously ventilating patients? Unfortunately, it has unclear utility when used in isolation. Extremes in diameter and size of IVC can be quite helpful. It is important to remember that patients who are spontaneously breathing can generate variable respiratory pressures, and that is why it is less reliable compared to positive and controlled mechanical ventilation. IVC collapsibility index can be used sometimes to support your decision to give or not to give fluid, and the formula is described in the slide. You want to measure the IVC diameter just distal from the entry of a hepatic vein into the IVC. And here you have two extremes. On the top left, you see an IVC which is plethoric and minimally collapsible. And at the top bottom right, you see an IVC which is very fleet and very collapsible. So these two extremes will be potentially helpful. Please pause the video if you need more time to review the slide. So what about IVC and fluid responsiveness in positive pressure ventilation or mechanical ventilated patients? It is overall more studied compared to spontaneously ventilated patients. However, there are some caveats. The patients should be passive on the ventilator, meaning not triggering any breaths. The tidal volume should be at least 8 milliliters per kilogram. The patient should be in regular cardiac rhythm. And again, like in spontaneously ventilated patients, the extremes are quite helpful. IVC distensibility index, which is also described here on the slide with a formula, can be used to determine whether a patient is likely or not to be fluid responsive. You can either use a 2D, which is shown on the bottom right, or you can also use an M-mode in order to calculate the formula and estimate the chances of your patient being volume responsive. Please pause the video if you need more time to review the slide. It is important for us to remember the limitations of IVC and fluid responsiveness. It should not be used or used with extreme caution in these following groups, such as patients who are mechanically ventilated but are triggering spontaneous breaths, patients who have high intra-abdominal pressure, such as patients with ascites and intra-abdominal hypertension, patients with right ventricular dysfunction, and moderate or more advanced tricuspid regurgitation. Please pause the video if you need more time to review this slide. Like mentioned earlier, the size and the collapsibility of IVC is quite often used by our cardiology colleagues in estimating central venous pressure. Please take a moment to review this slide and compare different sizes of IVCs and collapsibility and respective estimated CVP. Here in this presentation, we mentioned that IVC can be used in estimating the chances of your patient having pericardial tamponade. Plethoric IVC, which is defined as less than 50% collapsibility, has a 97% sensitivity for pericardial tamponade. But because there are so many different things which can give you dilated IVC, the specificity by itself is quite low. So if your patient doesn't have plethoric IVC, he or she is unlikely to have pericardial tamponade. But if your patient has plethoric IVC by itself, it doesn't mean that the patient has pericardial tamponade. Please pause the video if you need more time to review this slide. So in summary, cardiac point of care ultrasound is an essential clinical tool. It should be readily available and relatively easy to perform. It has the ability to change anesthetic approach and management, and it is important to remember its limitations. Finally, I want to thank you for your attention. If you have any questions, please do not hesitate to contact me on this email address provided on the slide. I wish you all the best and good luck.